Good evening and welcome everyone to the DOS Postgraduate Education Program, DOS-PEP as we all call it. And we are currently in the Strabismus and Neuro-Ophthalmology module, which is the third module after oculoplasty and retina series that we've been going through. And today we are in the 13th class of Strabismus, and we're discussing a very important topic, that is non-surgical management of strabismus, for which we have an eminent speaker, Dr. Digvijay Singh, sir, with us, who will be talking about this topic. Our moderator for this session is Dr. Abhipsa Sharma. She's a consultant at ASG Eye Hospital in Jodhpur. She's done a post-graduation from AIIMS Delhi and done a fellowship in pediatric ophthalmology from the prestigious LVPI hospital. She has also worked as a consultant at LVPI, and she has several awards and publication to her credit. Dr. Anita Gangar, ma'am, a senior consultant in the ophthalmology department at Gangaram Hospital in New Delhi, is our co-moderator for this session. And Dr. Digvijay Singh, sir, our speaker for the day, is a consultant at Noble Eye Care Hospital, Rainbow Hospital, and Sri Sitaram Bhartiya Hospital. He takes care of the pediatric ophthalmology, strabismus, glaucoma, and neuro-ophthalmology section. He's trained at All India Institute of Medical Sciences, New Delhi. He's done his post-graduation and senior residency in strabismus, neuro-ophthalmology, and glaucoma from AIIMS New Delhi itself. He's been a faculty at national international conferences, and he's been a part of various instruction courses in the subspecialty of his interest, and has over 70 publications, book chapters to his credit in the field of strabismus. He's also been a past president of UC, and we'll be happy to hear from Sir today on the important topic of non-surgical management of strabismus.
I would like to thank DOS, the entire team, for giving me this opportunity to speak to you all on non-surgical management of strabismus. So let's look at this in a very simple way that it's easy to understand for all of us. Strabismus. So what are the factors that are responsible for strabismus? I sometimes put these factors, particularly the ones that are going to help us with our non-surgical management, into a few A's. The first of which is ametropia or refractive errors. The presence of refractive errors is an important point which needs to be corrected, because presence of high hypermetropia, of myopia, of astigmatism, all can actually contribute to development of strabismus and breakage of our fusion. The next is accommodative dysfunction. So high accommodative convergence, low accommodative convergence, all these can actually cause, or a change in the AC by A ratio can actually cause strabismus and needs again to be corrected through certain optical means. Presence of anisometropia. So when there is a power difference between the two eyes, that itself becomes a reason for imbalance. I put next as amblyopia. So if one of the eyes is basically showing some suppression, or one eye is too dominant compared to the other eye, again, you can have strabismus, and this can be corrected non-surgically. Asthenopia, or you can even put this as poor fusion or poor convergence. And again, both this can lead to the eyes breaking away and going into exotropia. So the intermittent exotropia tends actually to get worsened as the fusion gets worse. Now let's look at the management options. The management options can, on the whole, be divided into three varieties: optical therapy, pharmacological therapy, and orthoptic therapy. So let's discuss this in these broad three subheadings. So let's come to optical correction. So optical correction can be done through the use of glasses or through the use of contact lenses. And let's come to the way to refract children and adults and how to achieve the best out of the optical correction. Remember that for children in refraction, retinoscopy is a very, very important skill for all of us to have, and we must all develop that. But refraction on the whole can be done by retinoscopies, by photorefractors, and by the autorefractor, what we use most typically. If you're doing it for a child, or the eye that is being refracted has to be looking at a far distance. Patient has to be comfortable. It's very, very important that there is, a certain distance-looking fixation. You don't want them to be fixing on any object that is nearby. And these are some of the things that you can look at achieving a very good refraction. And always take multiple readings whenever in doubt. Retinoscopy, as I said, is a gold standard for refraction for children, and it's still very relevant. You must all know the skill of how to do a good retinoscopy, and usually even the youngest of children can have very good retinoscopy, which can be done and is very, very useful in these cases. If you know the good retinoscopy, you'll have better results than you can achieve with any automated tool for a younger child, and particularly a child who's having strabismus, where the refraction is very, very important. Sometimes you can do it under EOA too. You get the child in a parent's lap, in a semi-dark room, while he's seeing far away, and you can do a retinoscopy just like you're seeing in this image here. The photorefractor is a good tool that we use to kind of differentiate in two ways. One, for strabismus, because it can tell you whether both eyes are aligned or not from the pupil reflexes that it sees. And two, it can also tell you if there's any anisometropia and what the gross screened refractive error is. You can't really use it to prescribe, but you can use it at least as a good screening tool, both for refractive error, anisometropia, and strabismus. You all must try using a photorefractor, or these videos are available on the internet. You can go through the YouTube and you can see how it works. The next comes the auto-refraction, what we typically do, and this is on the machine. Again, you have to be very sure where the fixation was. In squint cases sometimes, or if there's eccentric fixation, the eye may be looking slightly in a different direction when you're taking the AR reading, and therefore your reading may not be the most accurate reading at that spot. So again, one has to be careful, and doing it under cycloplegia works very well. My tips for doing a good AR is that you get the patient to be relaxed, get him to sit, let him see the target inside the AR machine for a few seconds, center your Myers on the pupil, and then let the machine automatically take a reading. If not, then you can take multiple manual readings. But do make sure that the reading is from the center and you're aware as to where the patient was actually fixing when the reading was taken. And then you have these open view autorefractors where they do away with the accommodative aspect, where the patient is seeing in a very far direction. And this is again something that you should be familiar with. These are portable, they're used in cam-based approaches, but they don't work very well with the strabismus sometimes. And though in cases where you cannot do a cycloplegic refraction, they do give you some element of probably a refraction closer to what you would get with a relaxed muscle of the relaxed tone of the eye muscles. What about cycloplegia? This is very, very important in squint cases, and therefore all your refractions have to be cycloplegic refractions. Remember, for esotropia, always and always use atropine or cyclopentolate, but preferably atropine under the age group of 5 years. Atropine is applied 3 times a day for 3 days in the eyes as a rice grain size from an ointment, and the refraction can be done on the 4th day. In slightly older children, you can get away with hometropine, but if there is an esotropic strabismus, atropine is very helpful and should be used. In exotropias, you could use hometropine as well. How to instill the cycloplegia is important, explaining to the patient and to make sure that you get it right. When you're using hometropine, you need to make sure that the effect has come. If you're using tropicamide, or you are using cyclopentolate, again, you need to know the duration between installation and when you're doing the refraction for maximal effect. Now let's come to how refraction can be useful for squint cases. For esotropias, you have to give a full cycloplegic correction. The correction that comes after you put atropine eye drops in the eyes. And this is very important because that full cycloplegic correction is the only way that you'll be able to achieve full relaxation of the ciliary muscles, and the accommodative part or the refractive accommodative part will get corrected. The cycloplegia of choice, as I said, is atropine in these cases. And in cases of very high AC by A ratio, where you are getting much more esotropia for near as compared for distance, bifocal glasses are useful, and these bifocal glasses should bisect the pupil through the center. You're not wanting the D-type bifocal glasses here. Sometimes, for esotropia, you will need to kind of occlude the eye to make sure that the other eye is straight, and therefore, that is an additional thing that you can do, where you make sure that the eye is looking straight when you're doing the refraction. Otherwise, sometimes the child if that eye is slightly strabismic, you get an erroneous reading when you're doing it. In exotropias, appropriate refractive correction is very, very important. For myopes, give the full myopic correction. For hypermetropes, the as close as possible to the optimal hypermetropic correction. And for cylinders also, we try to give the right amount of cylinder to get the maximal visual acuity and clarity. And that's very, very important. Sometimes in exotropic cases, we do slightly over minus or under plus correction to help in increasing the fusion, because when there is more accommodation required, then the accommodative convergence increases and the eyes are able to fuse. So here we are taking benefit of the accommodative convergence by slightly giving over minus, getting the patient who's exotropic or an intermittent exotropia to converge slightly more, accommodate slightly more, and in result, converge slightly more. Even small cylinders should be corrected in exotropias and intermittent exotropias because they increase the quality of the vision of the image that the child eye is seeing. And therefore, when the vision quality is high, you get better fusion between the two eyes. And that becomes very, very important. Sometimes, you can do slight inward decentration of minus glasses also to get kind of like a base out effect to induce convergence in these cases. But this is to be done at the time when the glasses are being made. And you can mention this in your prescriptions. What about anisometropia and squint? Anisometropia, an appropriate correction should be done after doing an appropriate cycloplegic refraction. If there is a large anisometropia, then sometimes contact lenses may need to be used because the contact lenses can reduce the anisopenia between the two eyes and get a better fusion of the images. Sometimes, if there is diplopia, then one of the eyes can be, blanked out to prevent diplopia. And similarly, the dominant eye can be blanked out or fogged out, or slightly an optical blur can be done in cases of amblyopia to enhanced amblyopia therapy. Prism glasses have a very specific role in squint correction, and small angle squints can be corrected with use of prism glasses, both where the glass itself is prism or you have stick-on Fresnel prisms that you can use. It is also helpful in post-operative over and under corrections in squint to prevent double vision, which may be there in your restrictive paralytic squints or just post-surgery. And some prisms are also useful to induce convergence and help in that in the intermittent exotropias. Now, contact lens, with regard to squint, if I look at it, is there primarily in cases of high refractive errors. So you've got very high myopia, contact lenses can give you a clearer image. And similarly, in very high astigmatism, as you see in keratoconus, certain forms of contact lenses can give you better images, and the clearer images can induce fusion of the two eyes. Use of contact lens has also been described in nystagmus, where they say it helps reduce the nystagmus by giving a slight biofeedback. And of course, in aphakia or large anisometropias, contact lenses have a very, very important role to play. Yes. Let me now move on from the optical corrections to a few cases. Case 1, accommodative esotropia. Now here is a child who's having an esotropia in one eye, as you can see, and you've given the right appropriate full cycloplegic correction after atropine, and see the esotropia is corrected. Intermittent exotropias with good control can simply be corrected or controlled by using glasses, as you can see in this case. Accommodative esotropias with high AC by A ratio require bifocal glasses, and you can see this is the glass which is bifocal and it is bisecting the pupil, so the child sees the near only from the bottom segment and distance from the top segment. Partially accommodative esotropias, as you see in this girl, some of it gets corrected with the glasses here as you see, but slight amount that gets left after correction with the glasses needs a surgical correction. Prism glasses can be used, as you see in this child who's having a who had an exotropia earlier, underwent a surgery, went into an esotropia, was given prism glasses, and that small angle esotropia is fully corrected. So that's one example where prism glasses can come and help. So this sums up the optical treatment part of non-surgical management of squint. After this, let's move on to the pharmacological treatment part. In the pharmacological treatment part, There are two primary agents that we'll discuss. One is atropine, some of which we've already discussed in the refraction. This is useful for giving the best cycloplegic refraction that we can get, but also it can relax the accommodation and is useful in accommodative esotropias, as well as in certain cases of amblyopias, where it is used as a part of penalization or pharmacological penalization, where a child is not accepting the patching or occlusion therapy. The dominant eye can be given atropine, which blurs the vision, and therefore the amblyopic eye tends to get dominant. The other agent is the botulinum toxin, which is given is an injection in the muscle to paralyze the muscle. It is useful in certain cases of infantile esotropia, where you don't want to operate in the beginning, or you're not able to operate at a younger age, and gives some time for allowing fusion to develop, because when you give it in the medial rectus, the eyes will straighten out. It is useful in paralytic strabismus. Again, it is useful where there's a lot of diplopia and you know that you have to wait for the next few weeks for a spontaneous improvement to happen in a certain nerve palsy. The botulinum toxin can give you an interim orthotropia while you're waiting for that to happen. Consecutive strabismus after a surgery where you've done some procedure and again have ended up with a overcorrection, it can come in handy to allow the eyes again to fuse. And similarly, in certain restrictive cases such as thyroid eye disease, it may be used. But do remember, it can cause sometimes blepharochalasis, it can cause ptosis, and therefore it has, and the outcome is slightly unpredictable. So this is one of the, you have to do it very carefully and set the right expectations for the patient who's getting this treatment done. With atropine, similarly, you will have trouble with near vision, and sometimes the child would require a near correction as well, or the adult would require a near correction when you do it. Orthoptic treatment is in fact probably one of the largest groups of treatment that we use for non-surgical management of squint, and a lot of times people are able to achieve very good fusion with this. Primarily this works for cases of intermittent exotropia where there is an exotropia and you want them to fuse a little better. So orthoptics, literally the word orthoptics means straight eyes, and it aims to provide the best vision and the best binocular vision that there can be. And this is done through fusion exercises, through anti-suppression, where the amblyopia is to be taken care of and corrected. And it can also help in improving the excursion and amplitudes of eye movements, and in diplopia training, where you're able to use orthoptic therapy to train the person to ignore diplopia or overcome their diplopia. And this is more important in the non-comitant squints. So here's the types of therapies that are there. The ones you can see on top are home therapies, where you've got pencil push-ups. Essentially in this, what we are doing is we're asking the person to take a pencil and move it from an arm's length slowly while focusing on the tip. As they come closer, it will become a little double. They should focus, hold it. They can blink during the procedure and then take it back again. So this helps to enhance the fusion and the fusional convergence, and is very useful in convergence insufficiency and asthenopic symptoms. It can also help in intermittent exotropias to increase their fusion. The second image you see here is of the cat cards in the middle. These are two separate images of half a cat each, which the person has to fuse to be able to make it a single image. This helps them train on their physiological diplopia as well as fusion, and is again useful in correcting the intermittent exotropes or phorias. Very often the phorias will get better with these. The third image on the right is the Brock string, where you have a long string with some beads on it, and as the string is stretched out, the person who's got let's say a strabismus, or who's doing the exercise in exotropia, would look at the strings from near and keep moving far, far, far from one bead to another bead to another bead, and while maintaining a single image. So this is again a therapy that is used. You also have certain therapies known as the simple home orthoptic trainer, which Professor Pradeep Sharma had developed, where again you've got two images similar to what a cat card is, and you fuse them to create one image on a device that you can easily make at home. Patching therapy or occlusion therapy has also been used for intermittent exotropias, and this is primarily to help in anti-suppression as well as enhancing the fusion between the two eyes. And alternate patching therapy techniques have also been described, though they are of limited use. You see me on this photograph below doing a synoptophore exercise. And this, the synoptophore is a device which is used to fuse two images. It's a haploscopic principle. You've got two tubes you put different slides. And here you will use the fusion slides, where we use, in the beginning, you can in fact use the simultaneous macular perception slides, where you have a line and a cage. the solid object and a hollow object, and the person is supposed to simultaneously view the both and put the lion in the cage. And this helps this is the first grade of binocularity that develops. And even prior to this, sometimes anti-suppression exercises may need to be done in the form of pleioptics and flashing, where you flash a brighter light on the less dominant eye and a more dimmer light on the more dominant eye, and do an anti-suppression exercise, and then you shift to these simultaneous macular fusion slides, followed by fusion slides itself, where you've got very similar looking objects, but something missing in one which is not there in the other, similar to what you see on the CAT cards, and you fuse these together. And third slides are stereopsis slides, where you've got very similar images, slightly disparate, and you fuse them to create one image where you see one in front of the other. For example, if there is a cricket, 3 wickets of a cricket, 1 wicket may be in front of the other 2, and you will have to assess that. The last image that you see on the right is what the newer therapies have come in for a better fusion in intermittent exotropias. This is where you use a red and a blue glass in front, and they come by different companies. One of them is Binox, Emlago is what they call it. Then you've got by Cursi. And so there are many different actually companies which are available. And here you're given these random dot stereograms, as you see these dotted on this slide. And 3D objects are there, and it tries to help you, fuse, and also improves your stereoacuity, improves your fusional range, both convergence and divergence, as well as can increase and help you increase your adduction-abduction range, which also, by the way, the synoptophore does very well. So in a way, this is a dissociation of the two eyes using a duochrome glass, while in synoptophore, it's a true dissociation using the haploscopic principle. But these newer softwares are also slated to actually help in the improvement of the strabismus these days. So the take-home message is that non-surgical management of strabismus is definitely useful for certain types of strabismus. And most important probably among these are the optical corrections, giving the best image that the brain is seeing so it can fuse very well, relaxing the eye muscle tones so that the accommodation relaxes, therefore the accommodative convergence relaxes. And probably this would follow, followed by orthoptic treatments, and then comes pharmacological therapies or pharmacological agents, which probably are a little less used, but again are useful as a stopgap therapy, as to give time between your initial management diagnosis and waiting for some self-recovery in, let's say, paralytic strabismus, or your initial diagnosis of squint and giving time till a surgical therapy is done. Remember, in a lot of squints, of course, surgical therapy is the definitive therapy, but with a good fusional convergence, you can achieve good control and good binocularity. So I hope this presentation has given you a bird's eye view on the non-surgical management of strabismus and a flavor of the different types of therapies that are now available in the market these days. I'll be happy to answer any queries that you may have. You can write to me on my email, and this is the email ID, and I hope the panel will have a good discussion on this now. Thank you.
Thank you. Thank you so much, Dr. Digvijay, for that insightful talk. And definitely, it's a bird's eye view. It's a vast topic and very important for the residents to understand that surgery is not just the only thing for management of strabismus, but there are various other components that need to be understood. So there are a few questions that I can see here. Dr. Abipsa will be taking up the questions. So Abipsa, would you like to tell us something about the botulinum toxin use in strabismus? So which muscle do we inject, and what is the dose of botulinum toxin that is described for management of strabismus cases?
Thank you, Dr. Pranita, for the question. So, botulinum toxin is basically something which will paralyze an overactive muscle. So, the muscle that you inject depends on what kind of pathology you are dealing with. So, in cases of if you start in infantile strabismus, like infantile esotropias, in those cases, as you know, that the eyes are turned inwards and the medial rectus muscle is the one which is supposed to be acting more. So in those cases, we will inject the medial rectus muscle of either eye or both the eyes, depending upon the deviation, and it can achieve binocularity for some time. And again, in cases of sixth nerve palsy, as you know, that the LR is paralyzed, and in the same way, in the horizontal deviation, the MR is overacting. So in those cases, like if the palsy, you know, it is an ischemic palsy and it is not related to any other pathology, in those cases, if the palsy is not getting recovered within 2 to 3 months, we can try and inject the medial rectus again in these the lateral rectus in these cases, so that the eye can become orthotropic. I'm so sorry, I said it wrong. We have to inject the medial rectus in these cases so that eye can become orthotropic for the interim period. So what interim period we are talking about is that this toxin usually has an effect for only 3 months. That is the maximum time. 3 to 4 months is the maximum time it can work. So in even in infantile esotropia cases, also in cases of, again, LR palsy, as I said, in those cases, the squint can come back. You should always have this thing in mind. And in cases of LR palsy, again, if the muscle, the medial rectus muscle goes into contracture for 6 months or so, so in those cases, uh, in those cases, that contracture we can reduce initially, so that later on we can do a recession and resection procedure instead of doing some vertical rectus transpositions along with the MR recessions. So that we can give the lateral rectus muscle to have some time to recover in those cases, and patient can definitely achieve binocularity and can be relieved of diplopia. Again, the dose will depend on the age. So in very small kids, maybe 1.5 to 2 international units. And in cases like in sixth nerve palsy, you can give up to 3 to 4 or even 5 international units. Again, in cases of thyroid eye disease, where there is a lot of restriction, if 2 muscles or 3 muscles are involved more than the other muscles, which are overactive and restrictive, you can give botulinum toxin in those cases also. Even some people have tried even in the active phase also, so that the patient can be relieved of diplopia.
Thank you, Vipsa, for explaining it in such details. There are another couple of questions related to the prisms. So, can you just tell us about the role of prism therapy in paralytic and restrictive strabismus?
Again, prisms are basically what you can give are 2 types of prisms. One are ground prisms and the other are Fresnel prisms. So Fresnel prisms can correct up to 30 prism diopters. They come as attachable to the spectacles, and what we can ground inside the spectacles are probably not more than, in 2 eyes combined, not more than 10 prisms, 10 or 12 maximum. So if you have any paralytic or restricted squint which has a primary gaze deviation of around 10 to 12, in those cases you can give ground prisms, and if the deviation is more than that, you can try with Fresnel prisms. But what most important is to know is that the prism that we are giving has to correct the squint and diplopia only in the primary gaze and in the down gaze. We do not target the side gazes or the up gaze, because primary gaze and the down gaze is the most important gaze that we look at during our usual
Daily
daily activities. So that is what we have to think. And again, in restrictive strabismus, again, like in cases of trauma and in cases of thyroid eye disease, in these cases, again, till you are waiting for surgery, like you wait for the inactive phase to come in thyroid eye disease, again you wait for at least 6 months or 3 consecutive visits of the deviation to stabilize in case of traumatic cases. In those cases, you can give prisms interimly so that the diplopia can be relieved.
Yeah, I think also a lot of time the postgraduates are asked that the child patient has esotropia and you have to give prism. So how will you put the prisms? How will you prescribe it in the glasses? So base and apex, can you highlight on which direction the base and apex has to be?
So in cases of esotropia, or in any case, the only thing that you have to remember is that the vision, the basic principles of physics is that the image will be formed towards the base of the prism. So you have to give base in prisms in cases of esotropia. Why? Apex in prisms in cases of esotropia. Why? Because the image will go out. The base will be out and the image is going to go out like this. So that is the prism that you will give. So it will depend on where you want to go. So from ESO, you want to grow from in to out. So the base has to be out.
Right.
Again, in exo, you have to come from outside to in. So the base has to be in.
Yeah. So in whichever direction you want the eye to move, that is where you want the base to be.
Yes.
Right. Okay. I think that's something very important because often in their vivas, questions are asked about how will you place the prism, and students tend to get confused on that. Another question on prism is, can you elaborate about the prism adaptation test?
So prism adaptation test is basically a test which you do pre-surgery in any patient so that you can understand whether the patient will have, for what amount, what degree of prism the patient is going to have fusion. So whatever for example, in case of intermittent exotropias, so in those cases, the patient might have a squint of around 40 prism diopters by your cover test. But if you give them 40 prism diopters in their glasses and just ask them to move around for 1 hour or so, they will have some sort of fusion, and then you can decide whether that is the angle of the surgery that you have to do. Also, in cases of patients who have probably a sensory exotropia or a sensory esotropia, in those cases, it is possible that they might have eccentric fixation. So, in those cases, if you operate more than what they can fuse, they will have diplopia after surgery. So, in those cases, also prism adaptation would come into play.
Okay, I think that's also a very useful practical tip on the use of prisms. So we heard a lot about the different cycloplegics that were described for use in management of esotropia. A lot of time questions are asked about the adverse effects of the various drugs that are used for cycloplegia. So any particular drug about which the adverse events are important to know for the residents?
So the most common that we use in infants is atropine. So for that, you have to understand and tell the patients that the parents basically that the baby can have flush on their faces and even they can develop a fever. So the fever, if it is more than 100 degrees, they have to discontinue the drug. They should not use it. If it is still that, they should be able to manage it with probably a syrup of paracetamol or something. So you have to tell every parent. Not every patient is going to react to the drug like that. But whosoever does, the parents should know about it. Again, cyclopentolate is one drug that is very commonly used. Nowadays, even for patients above 3, we sometimes use cyclopentolate and tropicamide plus phenylephrine as cycloplegic so that we can achieve a similar kind of cycloplegia as atropine. So in those cases, you have to remember that the patient should not have any neurological deficits. You should not use that drug in cases of cerebral palsy or any patients who have had seizures. And if possible, you should monitor all patients for at least 2 hours, 2 to 3 hours in the OPD, so that they do not develop any adverse event while you have given them cyclopentolate.
Yeah, I think what you've highlighted about cyclopentolate is often that residents tend to forget because the entire focus is on atropine, and that's one of the more commonly used drug. But some examiners do tend to ask about the adverse effects of cyclopentolate, and they need to remember the neurological adverse effects that you have rightly highlighted. So another question that has come is how to treat eccentric fixation that you just talked about. That if there is an eccentric fixation, how do we treat it?
So eccentric fixation, why it is happening is, the basic thing that you need to understand is that for a very long period of time, the patient has had either just a strabismus, which is causing amblyopia, and an non-harmonious anomalous retinal correspondence. What that means is that an extrafoveal spot has taken the fixation as compared to the fovea in the non-dominant eye. So in those kind of cases, we have to first give the full cycloplegic correction so that the patient can see as clearly as possible from that non-dominant eye. What have been tried is, you can give either patching and see whether the patient can achieve a straight vision with that. If not, then other things that have been tried are pleoptics, like sir had told in his talk, the visioscopes. And the third thing is that you can put possibly a red filter in front of the non-dominant eye so that the fovea is getting stimulated as compared to the extrafoveal spot. The only thing that you need to remember here is that the extrafoveal spot cannot have the same kind of vision potential as compared to the fovea. So you always have the advantage of stimulating the fovea in these cases. Sometimes you can even do a squint surgery before, but you have to see that the patient has had eccentric fixation and will not develop diplopia later. And then you can continue with all of these exercises.
I think you have very well covered all the points that were really important for the residents to know, because often their entire focus during management of strabismus relates only to the surgical aspect. But it is very important to know that there are various non-surgical aspects also that needs to be remembered, including the glasses, optics, and the various therapies and exercises that we have discussed about, and the prisms, which are also something very important to understand. So thank you, Abhip sir, for carrying forward the discussion, and we are really thankful to Dr. Digvijay sir for taking up this lecture on the non-surgical management of strabismus. So with that, we'll conclude today's class, and thank you, Abhip sir, for sparing your valuable time with us.
Thank you, Dr. Pranita. Good night.
Night.